Welcome to Season 2 of Derms on Drugs, a video podcast brought to you by Scholars in Medicine, the best educational platform in dermatology and provided at no cost to medical providers. Derms on Drugs is where cutting-edge derm meets hit or miss comedy. I'm Matt Zires from Doc's Dermatology, and each week I'm joined by my residency buddies, Dr. Laura Ferris from the University of North Carolina and Dr. Tim Patton from the University of Pittsburgh, where we use our 60 years of combined derm experience to discuss, debate, and dissect the hottest topics in dermatology. It's everything you need to know to be on the cutting edge of derm, and you'll probably have fun listening. New episodes drop every Friday on Scholars in Medicine, Apple Podcasts, Spotify, and other major podcast platforms. And as a reminder, there is a video component that has the key figures and tables from most of the articles that we talk about. This week, we've got one of our patented six-pack episodes where we are going to go through the stuff that has grabbed our attention in the literature over the last few weeks. And we are joined by our special guest, Dr. Scott Drew, a derm in practice for decades, about an hour north of me, also a member of Doc's Dermatology. So, Scott, as our special guest this week, we're thrilled to have you. And let's throw it over to Dr. Ferris for our first article.
Okay, I am going to start with an article from JAMA Dermatology, which was emollients to prevent pediatric eczema. So this was, I think, one that seemed like it got a lot of press. So this was the Cascade trial. And so this is, does moisturizing your baby prevent them from getting eczema? So this was a large U.S. study. So randomized trial, 1,247 infants, 25 clinics, and they started basically moisturizing babies with emollient every day before the age of 9 weeks. And then they looked and said, how many of them got atopic dermatitis by age 2? So the answer was the moisturizer group babies, they had an incidence of 36% of them versus 43% in the control group. So that's a risk reduction of 6.9%, relative risk of 0.84. So what does that mean? You got to moisturize like 15 babies to prevent one from getting atopic dermatitis. So interesting things. If you would think like, oh, okay, what should really matter is like the kids who are at high risk, they've got a high family history of atopic dermatitis, they're going to benefit more, but that is not true. The babies who did the best were the ones who did not have a family history of eczema, and also the ones who had a dog at home. So as a dog lover, I think that's good. So I think I could do pediatric dermatology now. I could just give out moisturizers and puppies to everybody. It would be a lot more fun. I wouldn't have to prior auth Dupixent.
You would be the most popular pediatric dermatologist with the kids and the least popular with the parents. All right, so I'm going to give my quick, what I would call criticisms of this article. So this is an area I've got a lot of interest. Been multiple studies have looked at this over the years. Most of them have showed no benefit of early moisturization. This one, here are the sort of concerns with it. Number one, the prevalence of the incidence of atopic dermatitis by the age of 2 was obscene. So, right, there's not a study in the world that has ever shown a prevalence of atopic derm of 40%. So basically at least double the generally accepted prevalence, and that kind of calls into question the diagnostic criteria they were using. Second thing, because the diagnostic criteria were either parent report of a healthcare person diagnosing them, the Children's Eczema Questionnaire, or that they've got a diagnosis of AD and a prescription, or that they got a diagnosis of AD with an over-the-counter or a prescription, or they met a modified UK working party, and there was stunningly different. So whenever we look at parent report of a diagnosis, it was about 30%. When we look at UK working party, it was 12%. So and when we look at UK working party, which was probably the most stringent, there wasn't a meaningful difference there. Also, an interesting thing that the people who had a first-degree relative with AD, there was no benefit. It was only the kids who were from a family who had no first-degree relatives with a diagnosis of AD. So, first study, though, that has shown a difference with moisturizing. My take on this whole area is that there are a lot of derms out there who are researchers who really want it to be the case that moisturizing babies prevents eczema. So far, the data has, and they've done really big studies that have all shown that it didn't. This was the first one that showed that it did. If you do enough studies, eventually one's going to randomly show benefit. And even this one showed if there is benefit, it's pretty small. Seems to me like we're barking up the wrong tree, thinking that moisturizing is going to prevent atopic derm, but this study, did show a difference. So that's
but
my
maybe
guess.
we're barking up the right tree with getting everybody a dog.
A dog, yes.
Walked
right
pass
into
it
that
up.
one.
Couldn't
That's
pass it
pretty
up.
good, Ferris. But there no harm in moisturizing babies. At least we don't think so.
I know. But our parents going to be like, I'm definitely going to do this once a day, every single day, because this study showed that it prevents this disease that my kid's probably not going to get. I don't see them motivated to do that.
And the other takeaway is for the parent who's like, I have eczema, I'm worried about my baby getting eczema. Will moisturizing them help? This study says no.
Right.
But there was no harm. Other studies have shown increased risks of skin infection in the moisturizing arm. This one did not.
Yes.
I just worry about the parent that brings in the kid that develops eczema at 1 year of age and then says, yeah, we could have stopped this. Why didn't you tell me?
It's true. All right. Scott, any comment?
Yeah, I think this reflects maybe the motivation of this study was the frustration that patients and their parents have with this disease state, because there's so much myth busting that's needed in the management of atopic dermatitis in children. The one that's so frustrating for me is somehow the idea that you shouldn't bathe your baby if they've got eczema. And, I think the whole soak and seal thing is the key to not so much prevent the disease from happening, but getting parents to buy into this is a life condition that's going to need some family-wide engagement until they grow out of it, if they're lucky enough to grow out of it. That you moisturize, that you use the right detergent, that you have the right diet, that you manage the asthma and the otitis, and it's not just skin. It is, and Matt, you probably are more responsible than anybody for creating the idea that this is an atopic syndrome, not
a single disease
skin problem.
Yep.
So whether it's moisturized from the day you're born or whatever regimen we're doing, is to let parents know that the skin person, the four of us and all of our colleagues, are the people that should be the home of this disease management, and that this is not going to be here, take a pill or use this or suck flaxseed oil every day, whatever the current myth is, that this is a science-based disease.
All right, Pat. All right, let's move on. Pat, what do you got?
Yeah, so my first six-pack was Modernizing U.S. Sunscreen Regulations, How Newer Filters Can Improve Public Health by Turner et al. In the June 2025 edition.
Sorry, I fell asleep for a second.
Of photodermatology, photoimmunology, and photomedicine. We recorded a recent episode yet to be released where we discuss sunscreens in depth with Dr. Woolery Lloyd. So I don't want to go too much what we already discussed. One of the things we didn't talk about was some of the newer agents that are available in Europe, and they may be available in the U.S. soon. So before discussing the agents, the paper is a section about how sunscreens are regulated in the U.S. versus Europe and Asia. In the U.S., sunscreens are regulated as over-the-counter drugs. Europe and Asia regulated as cosmetics. There's a section that reviews the sunscreens approved for the U.S. and goes through the generally recognized as safe and effective categories. Then there's a section comparing the regulatory processes for approval in the U.S. and Europe and South Korea. Section touches a little bit about how UVA protection is marketed differently in the U.S. compared to Europe and Asia. And then it focuses on the specific sunscreens not yet available in the U.S. First, there's bimotrizanol and bezoktrizol, organic broad-spectrum sunscreens. They have high molecular weight, structurally large, so absorption is very low. I think that's going to be helpful. Some of the medications that got kicked over to the generally recognized as safe and effective category 3, meaning the FDA needs more data. The absorption was one of the bigger problems there. Apparently, absorption is 0.01% in some studies. Endocrine disruption is also not a concern based on certain testing that was done. Other two ingredients reviewed were terephthalidine, I screwed that up, dicamphor, sulfonic acid, TDSA, and drometrazole trisiloxane. Also, broad-spectrum organic filters have shown little absorption after topical use. These all have trade names. So bemotrizinol is Tinosorb S.
So, Pat, and here, for anybody who doesn't quite get this, what's the benefit of an organic sunscreen, which just means it's a chemical, not a physical, versus why would it be better if these came out?
Patient compliance and use, right? The mineral sunscreens go on very pasty. These go on very, very nicely. Something that is cosmetically acceptable is going to be used by the patients. These are being used all over Canada, Europe, Asia, and they're the ingredients that are in some of the more popular sunscreens because it has that broad spectrum activity. That also adds in a lot, the UVA, pigment darkening, anti-aging effects. So kind of crazy that the United States has the system that it has to get these medications approved. I just thought it was something we had just talked about, and it just came out. And, we may see, especially bemotrizinol is Tinosorb S is the brand name. We may see that within a year being approved. It'd be the first new sunscreen approved since like the 90s.
That'd be sweet. Okay. Yeah. So
it would be good, but I'm like, is this our hill to die on as dermatologists? Like, we've made the point. I don't know. Sometimes I feel like we have such bigger fish to fry than what when the FDA will approve the next sunscreen. Like, we have sunscreens that work. Yes, it would be nice to have other ones, but like, how much
I think it maybe delves into the deeper thing of the difficulty that the FDA makes bringing new drugs to market in America. Sometimes they're just working against us, and they're working against patients doing the same thing.
Yeah.
Yep.
I think there's a lack of education among certainly me about what agents are in what sunscreens. And I'll tell you my little experience there is in Southern Africa and even in the Horn of Africa. People want to be, and all over the world, perhaps they want to be one color, and sunscreens in the third world are not very common because there's this myth that they don't get skin cancer. And so when women particularly are enticed to use these products, the best actor that's added to it to achieve a homogeneous colorization, unfortunately, are laced with heavy metals. So these women who are trying to achieve dyschromia relief are putting lead and arsenic on their skin. And this is epidemic. I mean, happens from Namibia all the way to Sierra Leone, across the Congo to Somalia. And the amount of arsenic and lead that's used actually leads to CNS degradation. So not that this issue is particularly germane to that. However, over-the-counter medications in non-regulated countries like we have are really problematic. And I can tell you stories and show you pictures of patients that really have been injured by what we would consider cosmetic usage.
All right, I'm going to jump on. So I'm taking a different tack on six packs, and I'm presenting 6 quick hit one-liners that I'll give you guys just a chance to comment on very briefly. Number 1, type 2 immunity links eczematous and lichenoid eruptions caused by immune checkpoint inhibitors. Basically, what they did here was look at people who got eczematous eruption or lichenoid eruption from an immune checkpoint inhibitor, compared the immune profile to normal eczematous dermatitis and normal lichenoid eruptions like lichen planus. And what they found was that the lichenoid eruptions with immune checkpoint inhibitors are Th2 driven. And which makes sense since we think, Dupy works for them. But what was interesting to me there is that I generally put a histologic reaction pattern together with a type of immunity. And I've always thought of, if it's lichenoid, it's Th1. And what this tells me is that lichenoid does not tell you the immune pattern. So I now think that if I get somebody with lichenoid and spongiotic combination on a biopsy, I'm going to assume that is a Th2 type reaction, that the spongiotic is primary, and I'm going to treat it as an eczematous disorder. So that was kind of the interesting takeaway there. Any quick comments on that one?
It fits. It works. Dupi works well for lichenoid drug reactions to immunotherapy. So
okay, all right, Nick.
Yeah, I would think lichenoid. I'm going to try roflumilast first, but now this paper has me thinking maybe the lichenoid in those patients is Th2 and try Dupi.
Yeah, so I think if you get lichenoid and a hint of spongiosis, go with the spongiosis. All right.
I think the message there, Matt, is people who are on these drugs don't need to stop them because they develop a cutaneous side effect, that we can manage them and let them stay on their drug and give them hope that they otherwise would not have.
Yep. All right, next. Alopecia areata, whenever the JAK doesn't work well enough, two good options came out. Number one, mini pulses. So there was one, it was a randomized controlled trial of they used betamethasone on weekends. Main takeaway for me here, because rather than betamethasone, I think we ought to be using dexamethasone if we're going to try and do this. The type of regimen that you would use here, and you could consider doing this as monotherapy or combining it with a JAK. It would be something like dexamethasone. Let me see here. What did I think that something like Dex 2.5 milligrams Monday and Friday or Saturday and Sunday in a kid, or 5 milligrams Saturday and Sunday in an adult. Using a regimen like that, they got salt scores went from an average of 50 to an average of 25. That was monotherapy, not combined with a JAK. The one that was even more interesting was a case report looking at they put somebody on a JAK. They didn't really regrow for a long time. Then they had them do high potency steroid under occlusion. So put the high potency steroid under occlusion on one half of their head, wear a shower cap overnight. That half of their head regrew hair. The other half did not. Then they did it to their whole head and they regrew hair and they maintained the hair with just the JAK inhibitor. Main takeaway is if you put somebody on a JAK and they don't get better after 3 to 6 months, do clobetasol under a swim cap at night until they start to regrow. Once they've got decent regrowth, stop the clobetasol under occlusion and the JAK should maintain it. I don't think we need any true real comment on those two other than it'd be reasonable to do the clobetasol under a swim cap at baseline. Like to start doing that whenever you first start the JAK wouldn't be unreasonable. Then once they've got the regrowth, you stop the clobetasol, just keep doing the JAK. Next one, good study showing that it was CeraVe versus regular moisturizer. It was a 2-arm study, literally meaning they put CeraVe on one arm, regular moisturizer on the other. So 2 arms involved. And they showed that transepidermal water loss changed the same in both. But the arm that got CeraVe, whenever you did tape stripping, it was more resistant to it. When you did sodium lauryl sulfate irritation, it was more resistant to it. And it was harder to basically interrupt the stratum corneum. So we're starting to see more studies showing that CeraVe truly is different from other moisturizers. Kind of goes back to the paper Ferris talked about, suggesting that we shouldn't just be asking, does moisturizing help? There probably is a component of, maybe if you did CeraVe from birth on, it would work better. Right? I'm not saying it does. We don't have any data for that. But next one, that was interesting. First study, and this one, I was so bummed to see this. This was a trinetic study where they looked at cardiovascular and thromboembolic risk in patients on JAKs compared to Dupi, methotrexate, or cyclosporin. And they did show a higher risk of DVT and PE, about 1,000 patients in the JAK inhibitor group, 1,000 patients in the Dupi group, higher rate of DVT and PE in the JAK inhibitor group. Multiple other studies have shown the opposite, but the big thing is this is the first study I've seen that showed a difference. So I now cannot say there is no evidence anywhere, not a single study anywhere that shows an increased risk with JAKs. Now we do have one study that shows it. We have multiple studies that show the opposite, but we can't say there are no studies that show an increased risk with JAKs. And then the last one, Trelo as an alternative for tralokinumab, or Adbry as an alternative for people with Dupi-induced arthralgias, case series of 15 patients. Lead author was Chris Bunick, really smart guy out of Yale. And his explanation for this was published in JID, which basically is using thermodynamics to talk about the difference between Trelo, Lebri, and Dupi. And the main takeaway was that Lebri may have some indirect IL-4 blockade. So because of the way it binds to the IL-13, or not that it binds, the way that it allows the IL-13 to bind to the IL-13 receptor type alpha might reduce IL-4 signaling as well. Because IL-4 signaling for the type 2 receptors, one half IL-4 receptor, one half IL-13 receptor. So if you take away the IL-13 receptor, now the IL-4 receptor doesn't have anything to pair with. So Lebri may have some IL-4 blockade associated with it. It's iffy and questionable. Because in that case series of 15 patients, they did have one Dupy arthralgia patient who got it on Lebri, but all of the patients they switched to Trelo did not have arthralgias. And so that was kind of just again an interesting takeaway. Maybe Lebri has more arthralgia risk than Trelo, but hard to say. But those were
ton of patients from the clinical trials and even post-marketing where we'd see that signal with Lebri.
You would think. But the people who get arthralgias that are bad enough to like really matter are probably 1 in 200. And so it didn't show up in the Lebri trials. It didn't show up in the Trelo trials. So I remain unconvinced, right? The main thing that I take away is, though, that I now have a reason to say, if you're the 1 in 200 people who get significant Dupy arthralgias, and I want to keep you on an IL-13, a drug that's targeting IL-13, I'm probably going to choose Trelo instead of Lebri. I now have something in the literature that gives me a reason to pick one over the other, because I'm always looking for like subtle differences in these drugs. And
it's helpful to say you could safely, this is a very reasonable thing to go to Trelo next. Like, because I think I've had patients get that and they fear going on another biologic.
Yeah.
So,
yep.
Helpful.
All right. That was it for my 6 quick one hitters. Ferris, what do you got next?
All right. So we're done with you, huh? We're not going to hear from you.
Oh, no, I got 6 more.
I find that hard to believe. Okay, I thought this was interesting. This was a paper from the JAD, which was I won't read the whole long title, but basically this multi-center study for autologous cell harvesting device to treat vitiligo. So this is a device called RECELL, and so this was
how do you spell that? How do you spell it?
RECELL.
Okay, so if anybody wants to look it up, RECELL.
Yes. And so they had 107 adults with stable vitiligo. They had every skin type represented. And basically what they did, it's basically a device that makes it easier for, the average dermatologist who's not like a person who does melanocyte harvesting to be able to treat vitiligo, sort of surgically. So basically, patients had vitiligo. They got like laser treatment, like CO2 or the KTP laser that treated the base, and then they harvest a shave biopsy basically, and then this device makes a cell suspension, and they can basically harvest like 5% of the area that is involved. They make this melanocyte like basically smoothie, and then you put that on, and then you can and then you basically let the area, it's like a little melanocyte transplant. So about 2/3 of patients had a 50% or greater improvement, and 42% of them had an 80% or greater improvement or repigmentation. Only 8% had full repigmentation. And the satisfaction rates were like 72% among patients, 84% among clinicians. And so people started to see pretty, early
Did they do anything
results like
together
by
with
week
it?
4.
What's that? Did they do anything together with it?
The laser.
They did do UVB, narrowband UVB with it as well.
So it sounds like for normal patients, if you could find a place that does this and get it covered, get this done, wait for it to heal, and then do either narrowband or Opzelura over it to try and protect those melanocytes that you just transplanted.
RECELL's primary target is wound, like grafting, right? So instead of taking this huge graft to cover up a defect, you take a little tiny piece and it like dissolves it and puts it in a liquid and you just spray it on the wound.
Yes.
So that's where RECELL works. And so they're like, well, could we do this for vitiligo instead of punch grafting or whatever sort of melanocyte transfer surgical that, nobody does.
Right.
Okay.
Or very few sites.
Very few
like,
sites.
and you don't get like, when I've seen the punch grafts, they get like little polka dots of repigmentation that kind of looks unnatural. So this is like a smooth cell suspension, right? And so I think it makes it technically more easy for, the average dermatologist to do. So I thought it was interesting.
And I'm on their website right now looking to see if there's find a provider. There's at least a contact us, so we could tell patients to email the company to try and find somebody in their area that does it.
Yeah,
Okay.
I don't know that it's actually like FDA approved. This is the clinical trial.
Oh, I thought it was.
If it's FDA approved for this actual indication.
Okay, got it.
Yeah, but I thought it's interesting.
Yeah.
I would never do like punch grafts and the more surgical stuff, but maybe if we had this in our toolbox.
Okay. All right, Patton, what do you got?
All right, my second May 2025 Journal of Dermatological Treatment. Intralesional triamcinolone for inflammatory acne, a comparative study of dose, efficacy, and investigation of a novel injection assistant device to enable self-administration. So basically, it's this little plastic thing, and you put a syringe in it, and patients can, at home, inject their acne lesions. And it's just as good as going to the doctor's office. I just logistically have no idea how you get them the medication. Like, they buy the plastic thing and then you just write for the syringe and they go to the pharmacy and get the syringe. I mean, it's a neat device. I don't see how it is eventually going to be implemented, if it's going to be implemented.
Well, by the way, I got to jump in and say I just asked AI. So first, RECELL is FDA approved for vitiligo.
Oh, it is FDA approved already. Okay.
And I asked, where can I find a provider who does it? And it said that I do it, and I do not. So AI certainly got that one wrong.
So maybe it's not FDA approved.
Maybe it's not FDA.
Who knows? Yeah.
Who knows? Okay. So, Patton, you going to start giving this to your patients?
It's not out yet. It was written by a company, but like most Mostagani, he was an author on it. A guy from Stanford. So they're working with the company to get this. I've
had friends. I do very little intralesional tack for acne because I've had like friends, like people I know in my community, come in and have done 1 mg per 1 mg per ml or 2 mgs per ml, and it gave them a dent that they always fill back in, but for like a year they had a dent, and I was like, oh my god, I hope that thing. They'd be like, it's still not better. Eventually,
no, I agree. I can't imagine putting this in the hands of patients.
I couldn't either, but
I guess the pearl, when you have that happen, and some people probably know this, but worth mentioning, is flooding with normal saline. So if you do have somebody get fat atrophy from injecting a lesion, flood it with normal saline. That does help to reverse it.
Okay. All right. I've got 6 more quick ones.
What? You were allowed 6 total.
I'm doing 6 more.
All right.
They'll be quick.
Like
all right. So first,
pack.
You have somebody they go get a sentinel lymph node biopsy and they get anaphylaxis or a drug reaction afterwards. Most likely it could be the patent blue V dye, or there's also this isosulfan blue that is the dye that they use. So if that person came back and they were like, what do you think they was allergic to or whatever, you can have them use methylene blue if for some reason they needed another sentinel lymph node biopsy. Wow. That was number 1. I didn't even know that allergy to the dye was a thing.
And then if they had dapsone toxicity and a sentinel node biopsy, we would kill.
You're good for all of it.
2 birds with 1 methylene blue scone. It'd be great.
That's true.
All right.
Burning mouth syndrome. Turned out that if you patch test people and they're allergic to a dental metal, removing it did not help. But if they were allergic to balsam of Peru, a balsam of Peru diet may help. So what I recommend there for a balsam of Peru free diet, AI it. Just ask AI, how would you follow a balsam of Peru free diet? The main things, though, are tomatoes, spices, and so that includes vanilla and chocolate. Those are the big things, and citrus. So tomatoes, citrus, and spices are the three big things in balsam Prue. Might be worth trying in burning mouth syndrome patients, but difficult patients. Next one, chronic idiopathic enodosum did great on off-label apremilast. So another thing to add to our roflumilast list of stuff. So now roflumilast would be now my first line go-to for enodosum. Frontal fibrosing alopecia, case report of it stabilizing and maybe improving with topical latanoprost. So this is generic Latisse. You get the little eye drops, but instead of using an eye drop, you put a drop in your hand, dab it on, rub it around your frontal fibrosing alopecia.
That was the least. Those pictures were the least convincing pictures I've ever seen for any drug being effective ever.
They said it's stabilized. So really the pictures just showed that it didn't get any worse.
Okay.
But there are a couple of other reports for that as well. For me, first line for FFA, intralesional TAC, topical JAK inhibitor, probably topical tofacitinib, which you can get 10 grams for about $35 from compounding pharmacies, and oral roflumilast. Then the next one after that, cheilitis granulomatosa. My go-to over the years has been injecting TAC into their lips and giving them azithromycin or doxycycline. So it was a case report that failed, and they gave them oral metronidazole in addition to a shot of Kenalog, and the oral metronidazole worked great. My first line for colitis granulomatosa now would probably be intralesional plus roflumilast, although that's not been reported in the literature. But this was just if you do intralesional, and usually what you do is 0.1 cc of K10 in like 4 shots along each lip.
Do you do Humira? You ever do Humira for us?
I only in patients who also, so I had one girl who had it and it was the manifesting sign of Crohn's, and the Humira helped, but I've never used Humira in someone who didn't also have inflammatory bowel disease. And then the very last one, that metformin or SGL2 inhibitors, either one of those, when people with HS went on them, cut their risk of death in half. And so there was some data that HS people have a reduction in life expectancy of 20 years because of the severe systemic inflammation with their HS. And so this data was like it was a Trinetics or database or something like that, showed that either metformin or a SGLT2 inhibitor reduced the risk of death by about 50%.
Crazy numbers.
Crazy numbers. And so now I actually think that most people with HS, if they have any active disease, should probably be on metformin additionally, which is an unbelievably safe drug, like unbelievably safe drug. People, I often hear people go, well, I would never prescribe it, but I'll tell them to talk to their primary care doctor. If you prescribe doxycycline, metformin is a much safer drug than doxycycline, like much safer drug.
Right. And it also upsets their stomach. So it is just like
it is just like that. Although at the doses that we talk about here, so either 1,000 extended release once a day or 500 BID would be the typical doses we would use for like HS. Really unlikely to see much GI upset with.
Right. And they will not be like, you don't risk hypoglycemia. I think that's the other, there's not like a true real risk of hypoglycemia. I think that's what scares me.
Yes.
I guess I've used metformin for HS and haven't been impressed with the results that it has in HS. Did they tie in what?
Nobody's died. So you might be onto something.
No, but they didn't tie it into how their HS responded, right? This is just, so that may be the difficult part. Like, I'm giving you this because it's going to save your life.
Yes. Now, I would never use it as, I can't see using it as monotherapy for HS. I could see like roflumilast plus this, most likely either Humira or Bimzelx or Cosentyx plus this plus roflumilast, something like that.
I don't see any HS patient rejecting that. Those patients are so desperate and they have been misinformed for so long. And the newer agents, that Bimzelx, et cetera, and the JAKs that are coming out are really offering hope to a population that's been so disenfranchised. I think this would be a well-received agent.
I think it's an easier drug to use even than spironolactone. You're not worried about potassium, right? It's a really, really easy drug to use. The other place that it's got some reasonable data is in acne, and in a few other places as well.
Yeah. The results were so impressive. It's hard to argue that they shouldn't go on it.
Yeah. I mean, a 50% reduction, and it was a substantial number of patients that were in this.
And I think they did propensity score matching pretty well.
Yeah, they did it with and without propensity score matching, and it was a big reduction in heart attacks, strokes, heart failure, peripheral vascular diseases, and death. And we're talking like 5,000 HS patients versus 70,000 people with HS without metformin. So we're talking like big numbers.
It works better if it's given with a dog.
Exactly.
And moisturize every day.
And moisturize.
You went through those so quickly. People are going to give their HS patients pulse dexamethasone, shower caps with clobetasol, roflumilast,
and IV methylene blue.
Well, so they can re-listen as many times as they want. That's part of the idea here. They can re-listen.
That's great. All right.
So I want to thank everybody for joining us. Scott, I really want to thank you for sticking it out with us for 3 episodes. This was fantastic. I hope that everybody that listened, hope you feel like you learned a few things. I hope you laughed once or twice, and mostly I'm hoping you're planning to join us next week. Until then, I'm Matt Cyrus.
I'm Tim Patton.
And I'm Laura Ferris, and we are Derms on Drugs.